On behalf of the American Heart Association, I would like to welcome you to today's Implementation Science webinar, Lipoprotein A and the 2026 ACC AHA Guideline on the Management of Dyslipidemia. Before we get started, let's take a quick moment to go over how to use the platform for today's event. Closed captions may be toggled on or off at any time. If you run into any technical issues, a simple browser refresh often resolves most problems. If that doesn't help, please check the system requirements or reach out to the Zoom webinar helpline for support. During the presentation, you're welcome to submit questions at any time using the Q&A feature on your control panel. We'll do our best to address them during the Q&A session at the end as time allows. At the close of the webinar, you'll receive a short feedback survey. We'd really appreciate your input to help us shape future Lp(a) education for better needs of your Lp(a) needs. This session is being recorded, and we'll upload the recording to our Lp(a) webpage. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the Heart Association. The American Heart Association does not endorse any product or device. It is my pleasure to introduce Dr. Donald Lloyd-Jones, a nationally recognized leader in cardiovascular epidemiology and the prevention. He is currently an Alexander Graham Bell Professor at Boston University School of Medicine, where he serves as director of the Framingham Center for Population and Prevention Science and principal investigator of the Framingham Heart Study. Previously, he spent 2 decades at Northwestern University, Feinberg School of Medicine, including 15 years as chair of the Department of Preventive Medicine, an author of more than 900 peer-reviewed publications and a highly cited researcher for over a decade. Dr. Lloyd-Jones has led numerous national cardiovascular guidelines and served as president of the American Heart Association from 2021 to 2022. Thank you for joining us today, and the floor is yours.
Thank you so much, Kelly. I'm really excited to see how many people are joining us for this special day, World Lp(a) Awareness Day. And I think there's just so much we're learning about this very interesting molecule. So I'm happy to share some of the current knowledge about Lp(a). And then I'm going to be joined by my colleague who you see on the screen there, Dr. Frank Qian, who is a third-year cardiology fellow here at Boston University. He is also a postdoctoral trainee in our T32 training program and is destined for a career in preventive cardiology, very interested in lipids and preventive cardiology. And Frank has put together a few cases for us that we hope will be illustrative for how to think about and manage Lp(a) in patients with Lp(a). So Frank will be joining us again a little bit later on, but I'm going to start by perhaps just reviewing in the next 30 minutes or so exactly what we know about Lp(a), hopefully to set the stage for that and also for your questions. Terrific. So let's get started. I have no relationships with industry. I am a longtime volunteer for the American Heart Association and have the privilege now of actually being a little bit of a part-time employee as well. So today, what I hope to cover in this first 30 minutes or so is, what is Lp(a)? What does it do? And then we'll dive deeper into current prevention strategies, including lifestyle approaches, as well as LDL cholesterol and ApoB lowering approaches to control risk related to lipoprotein(a). And then we'll spend a little bit of time talking about some of the therapies that are in the pipeline for lowering Lp(a) directly. And we're very hopeful that those are going to also show us that they not only lower Lp(a), but actually can prevent future heart attacks and strokes. So then we'll finish with a little bit of information about how you can learn more about Lp(a). All right, so let's get rolling. I want to highlight, first of all, that just 11 days ago now, the new 2026 American College of Cardiology, American Heart Association, and multi-specialty dyslipidemia guidelines were published. And they feature 2 recommendations that actually hone in on some of the biomarkers that are particularly related to lipid-associated risk. The first is apolipoprotein B. We're not going to focus on that today, but it is a very important one. And if you're interested in this area, I would recommend you learn more about apolipoprotein B and how we're recommending using it both in the management of dyslipidemia after LDL cholesterol goals are achieved, but also in the assessment of individuals' risk, particularly if they have genetically high levels of LDL cholesterol or triglycerides. ApoB is a very useful molecule to help tease apart the cardiovascular associated risk with that. Now, newly recommended in these 2026 guidelines is screening with for lipoprotein little a in all adults at least once. So you see that here on the left of the green panel there. Measurement of LP little a is recommended in all adults at least once for atherosclerotic cardiovascular disease risk assessments. And then in those with FH, premature ASCVD, or high LP little a, we recommend cascade testing, meaning first-degree relatives of that individual should also have their LP little a measured as well. Why is that? Well, you see here in the bottom table that individuals with elevated LP little a levels are at enhanced risk over and above their traditional risk factors for developing atherosclerotic cardiovascular disease, that is, heart attacks and strokes. And if the LP little a level is as high as 450 nanomoles per liter, that's equivalent, a 4 times excess risk is equivalent to someone who has genetic familial hypercholesterolemia. So the risks associated with LP little a are real, and it is important to measure it. So I'm going to take just a moment to remind us about the metabolism and the pathways that lipids take through our body. This seems a little complex, but it's helpful to understand because it sets the stage for understanding more about the lipoprotein little a particle. So when we ingest any kind of dietary fat, and you see that on the left side of this slide here in the exogenous pathway, of course, it goes down through our stomach into the intestines, and that fat is absorbed. But it's not absorbed in and of itself directly into the bloodstream or the lymphatics. It is packaged in these particles called chylomicrons. And those chylomicrons have typical proteins on the surface that create the structure of these particles. And the key one here is one called ApoB48. Now, those chylomicrons circulate through our systemic circulation, and what their main job is to drop off triglycerides, these very energy-rich lipid particles, drop off triglycerides for the muscles and for storage depots like fat cells so that we can actually store energy for later, in addition to using some of it now. Now, as those chylomicrons drop off triglycerides, they get smaller and smaller because the contents inside the particle are being taken out. And eventually, those chylomicron remnants are picked up by the remnant receptor in the liver, and whatever's left in there is stored in the liver for later use. So that's what happens in the context of a challenge of eating a meal that has fat in it. But of course, then there are often many hours between meals when we still need to be delivering energy to the body. And that's what the right side of this diagram shows us, is what's called the endogenous pathway. So in between meals, the liver will re-excrete particles that are high in triglycerides and also contain some cholesterol in order to continue to deliver energy to the tissues. And that's what you see here right in the middle of the slide, the VLDL particles, or the very low density lipoprotein particles. Characteristically here have an ApoB100 protein as their major structural protein. We're going to talk about ApoB100 later today, so keep that one in mind. But the same process happens. As these circulate through the systemic circulation, triglycerides are dropped off at either energy-consuming tissues or for storage tissues like fat cells. And as they do that, they get smaller, they become intermediate density, and then ultimately low density, or LDL particles, which contain very few triglycerides anymore and only typically contain cholesterol. So those are the LDL cholesterol particles that you and your doctor are talking about so often. And those LDL particles, typically in people who have normally functioning receptors in their liver, are picked up by the liver, and that cholesterol is then excreted into the gut, and around we go again. So that just kind of gives you a sense of why we think about particles, because they're really the actors in both this exogenous and endogenous pathway. And it's helpful to kind of understand that as background. Okay, that's the most technical slide I have today, but I think it's just helpful to set the stage. So let's talk about the main event today, LP little a. What is a lipoprotein little a particle? Well, LP little a particle is one of those ApoB100 particles, just like an LDL cholesterol particle, but it also has this additional feature that it has a protein that is covalently bound, that is tightly bound to the surface of this particle. And as you see here on the right, those circular connections here, that's a protein called apolipoprotein little a. And that is what defines this then as an LP little a particle and not just a run-of-the-mill LDL type of cholesterol particle. Now, the LPA gene that codes for this extra protein is actually one of the most potent risk factors for cardiovascular disease and, that we've noted, regardless of what your other context is, whether that's race, background, or other things. And we inherit 2 copies of this LPA gene. So we inherit 1 copy from mom, 1 copy from dad, and both of those genes are expressed in our blood. We'll talk a little bit later about which one can sometimes predominate, but we are a mix of different lipoprotein little a particles because we get 2 genes, 1 from mom and 1 from dad. Now, not all lipoprotein little a particles and ApoA proteins are created equal. Some of us make ApoA proteins that are much more elongated. In this area called the Kringle 4 type 2, there are more repeats of this part of the protein. And in other areas on the right, you can see people have Kringle 4 type 2 repeats that are much, much shorter. So not all of these ApoA proteins are created equal. Some of them are much larger, some of them are much smaller. The risk and the focus actually turns out to be on those smaller ones with the shorter number of repeats in Kringle 4 type 2. Because when you have a shorter protein, it's easier for that protein to get excreted. So that tends to get into the blood more often. And that's the one that really predominates in terms of what your levels of LP little a particles are, as opposed to the larger ones. So we'll talk a little bit more about that in a moment, but I just want you to visually get a sense for there are different sizes of this ApoA protein, and the shorter is actually the worse in terms of cardiovascular risk and your overall LP little a levels. Okay, so as I mentioned, there can be different numbers of repeats. There could be only 1 repeat in that Kringle 4 type 2, or sometimes we see people with as high as 50 repeats. That would be a very large protein because of all the numbers of repeated segments in that part of the protein. So wide variability. And again, each of us has 2 different versions of this. So you could have a short and a long. You could have 2 long, 2 short. It varies widely. And as I mentioned, it's those smaller forms of the protein that we really worry about. They lead to higher circulating concentrations of the lipoprotein little a particles, and they're the ones that are more associated with increased risk for heart attack, stroke, aortic stenosis, and other types of vascular disease. Okay, so how do we measure lipoprotein little a? And this is actually really important. The initial assays that measured the concentration of lipoprotein little a in your blood were what are called concentration assays that focused on the total mass of the protein. And those are expressed in milligrams per deciliter. So the units of measure are expressed as milligrams per deciliter. So that tells you about the total mass of the protein, but it actually doesn't give you the information that we're really interested in, which is actually the number of particles that have lipoprotein little a. And more importantly, how much of that is small LP little a, like we talked about. So newer assays have been developed, and they are expressed in nanomoles per liter. That is the concentration of actual particles of this protein rather than the total mass of protein in your blood. So those are the assays that if you're getting your LP little a measured, you want it measured with an assay that measures the nanomole per liter units. Those are more standardized so that you'll get the same answer typically from one lab to another, which is important. And they're much more reliable. So this is the type of assay you want to ask your doctor for if you're getting LP little a measured. Now, at the population level, we can sort of apply general rules to convert an answer or a lab test in milligrams per deciliter to a lab test in nanomoles per liter. But there's so much variability at the individual level that I don't really recommend doing that. It's just better to have the measurement done initially in the nanomole per liter type of assay. Okay. So when we think about, well, where is the risk involved? Is it differential between particles that have this Lp(a) protein and regular old garden variety LDL cholesterol particles, which we know are associated with the risk of developing arterial plaques? Well, there's sort of two ways to think about this. On the left, per particle, each Lp(a) particle, per particle is a little bit more risky than each individual LDL cholesterol particle. So if they were present in the same concentration, Lp(a) is more risky. It has features we'll talk about that would promote atherosclerosis or plaques more and actually promote blood clotting more than a garden variety LDL cholesterol particle. However, the typical person has about 10 times more LDL cholesterol particles than they do Lp(a) associated particles. And therefore, on balance, LDL cholesterol actually provides more of the risk associated with plaque development than does an Lp(a) particle at the person level, right? So per particle, Lp(a) more risky. When you think about the whole person, actually LDL cholesterol provides more of the risk in terms of plaque development. So I hope that's clear in the way we think about this. Okay, well, who has elevated Lp(a)? It turns out, again, there's wide variation by individuals. Here you see data from the UK Biobank, a very large study. In this case, they were able to look at 460,000 different individuals in the United Kingdom. And they did find some variation by background, race, and ethnicity, how people self-identified as white or black or South Asian or East Asian. And what you see here on the left is that for people who identified as white, they were typically of European ancestry. The median or middle value of lipoprotein(a) was 19 nanomoles per liter. We would consider that in the low range. Whereas for people who identified as black, most commonly of African ancestry, the median level or middle level was 75 nanomoles per liter, which is right about at the break point where we say that it's starting above that to be higher values of Lp(a). So we do see in the right here that there's broad variability in any racial ethnic group, but actually overall South Asian individuals have somewhat higher mean levels or average levels, and people who identify as black have significantly higher average levels compared with some of the other racial and ethnic groups. Now, there's been some sort of myth out there that even though Lp(a) is higher in people who identify as black, that's not associated with risk. Well, that's dead wrong. We now have a number of studies that show us that regardless of who you are, regardless of what your background is, the risk relationship between increasing levels of Lp(a) and risk is the same. So this is a universal risk factor for cardiovascular events, whether you are white, black, South Asian, East Asian, doesn't matter. If you inherited genes that give you a higher level, that is increasing your risk. And there's no reason to differentiate depending on your backgrounds. Okay, so why does Lp(a) cause cardiovascular disease? Well, the first is, as we said, per particle, Lp(a) particles tend to get into the wall of our arteries a little bit more easily. And once there, they can be chemically altered more easily and start to generate the process that forms arterial plaques. So that's sort of strike one. Lp(a) starts forming plaques a little bit more easily than a garden variety LDL cholesterol particle. But the protein, that ApoA protein that defines an Lp(a) particle, also has some really interesting other features. In addition to those differential numbers of repeats, there are domains in that protein that look like some of the things that actually lead to blood clotting or contribute to blood clotting in our body. So having Lp(a) doesn't tend to cause a lot of spontaneous clots in people, but if you're forming a blood clot for another reason, it can actually potentiate that clot because of the way that protein looks and acts in our bodies. So that's a key feature and almost maybe strike two of why having high Lp(a) increases your risk for cardiovascular disease. Now, just in terms of clearance, Lp(a) particles are cleared largely in the same way that LDL, garden variety LDL cholesterol particles are cleared through the liver, and then the cholesterol within them is excreted. Okay, so it's a reasonable question to ask, well, if this thing is bad for us, if it's associated with cardiovascular risk, why do we have it? Why was it conserved during evolution and we still have this protein? And as you saw, large numbers of people in the population actually have elevated levels. So why would that be? Well, remember, we didn't always live to an average age of 78 to 80. Often people were dying younger. And so cardiovascular disease wasn't as much of a problem earlier in our evolutionary history. But we know that it does lead to things like aortic valve stenosis and atherosclerotic plaques, heart attacks, and strokes. So why would we have kept this around? Well, the prevailing hypothesis is that because of those features that lead to a little bit more clotting potential, that it may help people who get wounded for some other reason actually seal that wound and heal a little bit quicker. And maybe even thinking about bleeding after delivery of a baby, perhaps bleeding is lessened in women who have higher Lp(a) levels, which would also tend to keep this protein around in the population. So those are some of the kind of interesting hypotheses about why this has been conserved. And I think given what we know about the biology of the protein, those are very interesting and viable hypotheses. Okay, so we do measure Lp(a). We now, as you saw, recommend measuring it in all adults at least once. But it's fair to say that at the moment, we don't have any therapies that directly lower Lp(a) levels in the blood. So why measure it then? Well, it's because, largely speaking, all the evidence points that this is a causal molecule, that is something that actually directly causes arterial plaques to form. So that's a good reason to measure it. But also because it is associated with higher risk of a number of different things that we want to be monitoring our patients for. Aortic valve stenosis, that is narrowing of the major outflow valve from the left side of the heart. Peripheral vascular diseases, the blood vessels typically feeding the legs. Deep venous thrombosis, that is blood clots forming in the veins, often in the legs. But also the major cardiovascular events, of course, of stroke, that is a brain attack, or myocardial infarction, which is a heart attack. Okay, so if you have elevated Lp(a), what do the guidelines, the new guidelines, say about preventing cardiovascular disease? Well, this is the general workflow for risk assessment in those new guidelines. And what we call this framework is the CPR framework. It's not that kind of CPR, which we apply to individuals who are experiencing sudden cardiac death. This is actually CPR for prevention. It's much more effective because we actually prevent the events in the first place. So what we start with here is estimating your 10-year risk for an atherosclerotic cardiovascular disease event using some new equations from the American Heart Association called the PREVENT-ASCVD equation. And then we'll put you in these 4 different buckets of risk: low, borderline, intermediate, or higher risk, depending on what the calculator tells us. And the calculator uses, as we'll talk about, a number of different variables to calculate your 10-year risk. Once we have that risk, we don't just immediately write a prescription for medication. We actually talk about it with the patient. And we say, okay, that's your overall estimate of risk, but I know special things about you. I know about your family history. I may have measured some other things that are relevant, like your Lp(a), for considering changes to that initial estimate in terms of what your risk is for cardiovascular disease. So we try to personalize that estimate in the context of telling you what we're thinking in terms of your risk and whether you might benefit from drug therapy to lower that risk. If we're still kind of on the fence, then we can use other tests like a coronary artery calcium scan to really determine whether you're on the fast track forming plaque and whether we really want to be more aggressive at lowering your cholesterol levels. And then we decide and treat. But again, the patient-doctor conversation, that sort of shared decision-making, is a really crucial aspect of every step of this process. Okay, so I mentioned the PREVENT-ASCVD risk calculators. These are equations that can actually be auto-calculated in your electronic health record if you and your doctor have measured the appropriate variables. And if we know some historical things about you, about whether you're a current smoker, what your current age is, things like that. But all of these tests are done routinely in clinical practice, so they should be available for the calculation. And then, as we mentioned, we use that initial calculation to put you in the low, borderline, intermediate, or higher risk groups of the risk assessment in order to start the conversation. And here it is. Then we have that conversation where we bring in personal factors related to that individual patient. And we particularly consider things called risk enhancers, things that aren't in those equations, but that should make us think even more about, is this someone who would benefit from being on drug therapy in addition to lifestyle? And notice highlighted here in the red box, lipoprotein a levels greater than 125 nanomoles per liter, or if you're using an older assay, and I hope you're not, but if you are, higher than 50 milligrams per deciliter would indicate individuals who are at above that risk threshold where we think it's likely pushing their risk higher. And that's where we actually then would kind of reconsider or reevaluate the personalized aspects of risk in that patient. So we often get this question, well, okay, I've got a somewhat elevated Lp(a). How does that change my estimated risk from step one when we use the PREVENT equations to estimate your 10-year risk? Well, there's no perfect way to do that, but the amount of Lp(a), will change the amount of risk elevation. More Lp(a), higher risk; less Lp(a), a little bit less risk. So this is just a kind of a back of the envelope way to understand how the Lp(a) is contributing over and above the traditional risk factors. So this equation you see here, take the predicted 10-year risk from the first step and multiply it by 1.11 raised to the power of the patient's Lp(a) level divided by 50. So this is sort of advanced stuff, but this can give you a back of the envelope way to understand how the risk is reclassified or changed based on the presence of Lp(a). And you see here a reference that can help you actually understand how to do that more. Okay. The other thing about Lp(a) in the conversation between the doctor and the patient is it might be a motivator for that patient. When we show them their coronary artery calcium images, or sometimes when we talk about other risk factors, that will make them more motivated to either try lifestyle a little bit more aggressively to lower their risk, and or if we're going to actually prescribe a medication, it may make them more motivated to actually adhere to that medication for the long term. So I like to bring in this information, again, to kind of juice that conversation and actually engage the patient a little bit more in their interest in preventing cardiovascular events. So thinking about Lp(a) as a motivating factor in your risk communication strategies, I think can be useful. Okay. So as we said, the thresholds for considering more aggressive action would be an Lp(a) over 125 nanomoles per liter. And we certainly, for everyone, should consider optimal and earlier control of all their modifiable cardiovascular risk factors. That background context matters even more in people with high Lp(a). And in people who already have clinical atherosclerotic cardiovascular disease, we may be more likely to aggress with the drug therapy in order to make sure we're achieving the goals that I'll talk about in a moment in terms of their LDL cholesterol level. So to summarize, lifestyle for all, and it's particularly important if that high Lp(a) is associated with a family history, because that is already telling you that they have an Lp(a) that seems to be more prone to risk. Okay, so the goals with lifestyle therapy, because lifestyle doesn't really change your Lp(a) level, there can be some modest changes, but nothing substantive. The goal is to reduce the underlying risk. So diet and physical activity, as we said, don't have much effect on Lp(a) levels per se, but they can reduce the overall underlying risk that we're, again, multiplying by the Lp(a) level itself. So they're very, very important, as of course they are in all preventive strategies. One way to think about how to quantify lifestyle and think about improving it is the American Heart Association's Life's Essential 8 platform, and you see that here. If you want to calculate your cardiovascular health score, you see in the chat there's a website so that you can do that. And you can do the My Life Check assessment to get your cardiovascular health score, which will vary from 0, which is terrible cardiovascular health, all the way up to 100, which is ideal cardiovascular health. And so this is what your score will look like on the website. And you can kind of get red light, yellow light, green light assessments of the 8 essential factors in the cardiovascular health. And then click through to really good content on how you can focus on whichever things you need to work on. The yellow lights and the red lights, let's say. But really good American Heart Association content associated with that. Okay, so what about drug therapy? Many patients will still need some drug therapy to lower their risk with or without Lp(a), but certainly in the presence of Lp(a), we may need drug therapy more often. Because we don't have definitive proof that the newer drugs that do lower Lp(a) directly actually lower heart attacks and strokes, we're still waiting on that evidence. Until then, the cornerstone of therapy remains drugs that lower the LDL cholesterol. Remember that ApoA protein is attached to LDL cholesterol-like particles. So if we can take away what the protein is traveling on, then we actually have shown that it does lower their risk. Okay. Now, this comes up a lot. Statins actually don't lower or increase Lp(a) levels substantially at all. So they really are just targeting the naked LDL cholesterol particles. They work really well, but they're not directly working through lowering or changing Lp(a) levels. And yet, as we mentioned, they do work, regardless of whether you have Lp(a) or not. Statins work with a similar relative risk reduction, but because people with high Lp(a) are at higher risk themselves, you get a greater absolute risk reduction in people who have high Lp(a). So statins remain the initial line of therapy for almost all patients with elevated Lp(a). Okay, so what's my personal approach? This is personal opinion here. Again, we're trying to remove the vector. What does the protein travel on? It travels on LDL cholesterol-like particles. So let's reduce those numbers of particles. That's really important. The NLA, the ESC, and now, yes, the American Heart Association guidelines all now converge on these numbers. For primary prevention, we at least want to shoot for a target of less than 100 for the LDL cholesterol. For high-risk primary and for secondary prevention patients, at least shooting for less than 70. And for very high-risk secondary prevention patients, at least shooting for less than 55. And you see here corresponding values of ApoB if you follow the new recommendations to also look at ApoB to make sure you control all the lipid-associated residual risk. Some data suggest that people with Lp(a), because of that clotting potential, may also benefit more or maybe more likely to benefit from aspirin therapy, but that should be a conversation with the doctor in terms of considering also the risk of bleeding from aspirin. So we don't recommend that routinely in primary prevention. Of course, for people in secondary prevention, especially if they have high Lp(a), aspirin is a critical component of treatment. Okay. Some of the newer medications like PCSK9 monoclonal antibodies do reduce Lp(a), perhaps by as much as about 25% on average. And that may be part of why they work, in addition to lowering LDL cholesterol. Another new medication, bempedoic acid, does not significantly change Lp(a) levels. And sometimes we get asked about ezetimibe, another non-statin lipid-lowering agent. Very, very mild reduction, on average about a 7% reduction in lipoprotein (a) levels. Okay, so what's the future? Well, very exciting, but yet unproven. We do have medications that directly lower either the production or the creation of these Lp(a) particles, and they work well at lowering blood levels of Lp(a). Pelacarsen, one of the first kind of out of the blocks. Here you can see dosing every 2 to 4 weeks with pretty dramatic reductions in the amount, so percent reductions in the amount of Lp(a) in affected patients. Another one, olpasiran, this works slightly differently by preventing the production of the ApoA protein. And you can see here with dosing every 12 weeks, pretty dramatic reductions in the Lp(a) levels of those patients that are sustained out as long as a year with 12-week dosing. A longer dosing interval with a different compound called lepodisiran. Here, just a single dose leads to, at higher ranges, remarkable reduction that lasts for, again, up to 48 weeks. And interestingly, even an oral agent that prevents the binding of that ApoA protein to the LDL cholesterol-like particles so that they can't actually create the full package of an Lp(a) particle. And we see reductions there in those particles as well. So we can reduce this. The question is, does that directly then lead to fewer heart attacks and strokes? And those are the trials that we're waiting on. And with those trials, we'll also get more safety data for these compounds just to make sure that they are as safe as we think they are from the initial data. Okay, so to wrap up, take-home points. We think that lipoprotein(a) particles are causal risk factors for atherosclerotic cardiovascular disease. They clearly enhance the risk, and the underlying context of the other risk factors really matters. So that's why at the moment we focus on managing those traditional risk factors, of course, with lifestyle and with medication in patients who merit that, where we think there will be benefit. Statins, ezetimibe, PCSK9 monoclonal antibodies, and perhaps other medications can reduce the risk with variable effects directly on the Lp(a). But the future of this, direct Lp(a) therapy does look bright. So far, we know we can reduce that. We know we can reduce it safely in smaller trials. We just need those endpoint trials to show us that heart attacks and strokes are going down as well as the Lp(a) levels. If you want to learn more about Lp(a), this is one of the pages from the American Heart Association, which has great content on that. And another one here, and you'll see in the chat, there's a link that was just posted if you want to learn more about this and what to do about elevated Lp(a). Okay, so now we're going to pivot, and we're actually going to look at some cases that Dr. Frank Qian, who I introduced earlier, third-year cardiology fellow at Boston University. He is a T32 postdoctoral fellow as well, doing some research with us. But he's very interested in lipids and in preventive cardiology. So Frank, thanks so much for joining today. And why don't you walk us through these cases?
Yeah, thanks, Don, and great to be with you for this really fascinating discussion. Thank you for that wonderful overview. I don't have any relevant disclosures, and so I thought I would just present a few hypothetical cases to kind of solidify what was already presented. So I have a patient, Miss L, who is a 65-year-old woman. She presents to clinic with you for follow-up after approximately 3 months after a hospitalization for an acute stroke. She developed some symptoms of right arm weakness as well as expressive aphasia, which thankfully resolved shortly after her arrival in the emergency room. She did undergo head imaging, which showed acute left MCA territory infarct without any hemorrhagic conversion. And then she also had a CTA, which ended up showing what was thought to be the culprit for the stroke, an 80% stenosis of the left internal carotid artery. Later on during that hospitalization, she was able to undergo an uncomplicated carotid endarterectomy. Her other stroke evaluation included a transthoracic echocardiogram, which did not show any evidence of left ventricular hypertrophy, but did show some aortic valve calcification without stenosis. She did have in-hospital as well as post-discharge cardiac monitoring that did not show any evidence of atrial fibrillation, again, pointing to the fact that we think this is due to that internal carotid artery stenosis. Here's her past medical history, some cardiovascular risk factors, including hypertension and hyperlipidemia, for which she was receiving treatment. She does have a former smoking history, as well as a family history of cardiovascular disease. And prior to her admission for the stroke, her home medications included daily aspirin 81 milligrams, as well as atorvastatin 10 milligrams, for which she was recommended for up titration in the past, but had myalgias with higher doses, and as well as lisinopril 20 milligrams daily. Her physical exam at the time of follow-up with you showed her blood pressure was reasonably well controlled. She does have an elevated BMI of 29, and then her laboratory values at her prior hospitalization showed an A1C of 5.3%. Her lipid panel is displayed there, and obviously because we're talking about Lp(a), one was checked and was found to be quite elevated at almost 300 nanomoles per liter. So at the time of discharge, she was initiated on clopidogrel 75 milligrams daily and did have her statin increased to rosuvastatin 40 milligrams a day. Now, at the 3-month follow-up, she did get a repeat lipid panel, and her LDL is now quite well controlled at 65 milligrams per deciliter. So Don, I'd like to ask you, what would you recommend for her lipid lowering strategy in the setting of her elevated lipoprotein little a in terms of specific therapies you would recommend, as well as her threshold for treatment?
Yeah. Thanks, Frank. I like this case as a really good, solid secondary prevention case in a patient who, as you mentioned, does have a pretty markedly elevated LP little a and the recent stroke. So very much like that she was switched from atorvastatin 10 to rosuvastatin 40. Most patients who do have, if they're real, statin-associated muscle symptoms, will tolerate a different statin. So it is absolutely worth trying, and we want to get them on the maximally tolerated dose. So switching from a lipophilic statin like atorvastatin to a more hydrophilic statin can often be a really good strategy, and patients will often tolerate the more hydrophilic one. And again, starting at that high dose, and if she does have symptoms, backing off is the right strategy rather than slowly titrating up to the highest tolerable dose. So I like what was done here. As you mentioned, we went from an LDL of 128 at hospitalization to 65, about a 50% reduction, which is what we'd expect from this dose of rosuvastatin. But is it enough? I would like to see her LDL cholesterol lower. The guidelines would suggest with that recent event that we probably ought to shoot lower for something less than 55. I think that's very reasonable. So she's tolerating the rosuvastatin, I gather, from what you're telling me. Great, we're going to continue that. Then the question is, do we need to add something more? I would propose that we should. She had pretty significant atherosclerosis. She had a clinical event from that. So we're not fully controlling her risk here. I'd like to see the LDL lower. I think a reasonable strategy, because we're at 65, we're not at 85. So it would be reasonable to think about ezetimibe here as an approach for this patient. We'd expect a further about 20% reduction in her LDL, which could get us to a nice lower level of the LDL cholesterol. Everybody's mileage differs, right? So she might be a good responder, particularly good responder, or less so. But I think that would be a reasonable start. If we were more like at 85 on this LDL, I might jump right to a PCSK9 monoclonal antibody because I have to move that LDL further to get to the lower goal I'd like to see for this patient.
Yeah, absolutely. And I totally agree about the point. If her LDL was, closer to 85, 90 range, I think PCSK9 inhibitor would be very reasonable, especially given there's some data showing direct LP little a lowering effects that, that might be one of the reasons they're found to be beneficial.
I like that.
And then thinking about her kind of overall cardiovascular risk profile, we did see she has, slightly elevated blood pressure, but also an elevated BMI at 29. What are some other therapies you would consider for this patient to sort of lower her global cardiovascular risk?
Yeah, it's a great question. I think the recent hypertension guidelines, also from AHA, ACC, and multiple societies, would say that she is not adequately controlled with that blood pressure of 135 over 85, and we should be shooting for a lower goal. So I think combining the lisinopril, which again, she seems to be tolerating well, with an additional medication, either a dihydropyridine calcium channel blocker perhaps, or thiazide diuretic would be a very good strategy. In patients with stroke, lower blood pressure is really important to achieve. So that would for sure be one thing. What do you think about her BMI? What might be things to consider there?
Yeah, I would say, certainly recommending weight loss would be a good strategy, but also if she was open to pharmacological therapy, then GLP-1 receptor agonist based on the SELECT trial has an indication for this population with a BMI above 27 and a history of ASCVD. She would certainly be considered a population that would be likely to benefit.
Yeah, really well said. Totally agree. So I think those are all conversations we should have with her.
Absolutely. And then the third thing was, we did see on transthoracic echocardiogram that she did have some aortic valve calcification, although no evidence of stenosis. How would you think about, given her LP little a, her risk of aortic stenosis going forward, and whether you would implement some kind of surveillance strategy?
Yeah, well, what's interesting, setting aside bicuspid aortic valves for a moment, for people born with tricuspid, quote, normal aortic valves, what we see in terms of the process of what leads to degenerative aortic valve disease and ultimately aortic stenosis is a process that looks very much like atherosclerosis, very, very much like it. And that can be accelerated by the presence of higher levels of Lp(a) particles. And so, while, again, we don't have any direct evidence of how to manage the Lp(a) per se, I think it does mean we want to monitor her more closely for the perhaps progression to aortic stenosis. And, that way we might capture what ultimately becomes asymptomatic severe aortic stenosis, before she could get into trouble. And, we now have some evidence that maybe intervening even on asymptomatic severe aortic stenosis may be something worth considering.
Well said. In the interest of time, I'll move on to the next case. So we have a 40-year-old man who is referred to Lipid clinic as he was found to have an elevated lipoprotein(a). He was recommended for testing because his brother actually recently had a myocardial infarction at the age of 45 years. He says he exercises regularly. He has no exertional symptoms. He is interested in learning about ways to reduce his cardiovascular disease risk, particularly given his family history. And here are some of his past medical history, as well as physical exam findings, just notably BMI slightly elevated at 27. He has otherwise fairly unremarkable A1C and renal function. And then his lipid panel showed an LDL that was sort of in that borderline range, 120 milligrams per deciliter, and then an Lp(a) that was elevated to 193 nanomoles per liter. Because we've been talking about the new cholesterol guidelines, I just also put his PREVENT predicted risk here. His 10-year CVD as well as ASCVD risk are both fairly low, and that he has a fairly low also 30-year CVD risk.
And Frank, maybe I'll just jump in for a second on that last slide. Thank you for providing the PREVENT equations. Just to hammer home the point, why didn't you prevent them for the prior patient?
Since their secondary prevention, they would by default be considered high risk. PREVENT is really meant more for sort of primary prevention before someone has a clinical event.
Yeah, exactly. So don't calculate it at all. It's not relevant in someone who's had an event. They are high risk. They need full board treatment. So it's really helpful as a decision aid, and starting that process we talked about. Calculate, personalize, reclassify only in primary prevention. So I see people kind of make that mistake sometimes, and don't misapply these risk scores. But Thanks for presenting them. And notably, you presented both the 10-year and the 30-year risk, which the PREVENT equations provide to us.
Great. So I guess as a segue, we saw that his 10 and 30-year CVD risk are quite low. In that sort of low risk category. Would you consider any other testing to kind of help you further risk stratify him, obviously with his family history?
Yeah, so it's a great question. You showed us that his 10-year ASCVD risk was 0.8%. Even with that Lp(a) elevated around 200, that's not going to push him into even the borderline risk zone in the next 10 years. Now that's a population level estimate, right? Like, could he be that 1 in 100? He could. So I think we need to say that to him, that he's doing an awful lot right here. But his risk is not zero. It is elevated by the presence of this Lp(a). So let's think more about that, right? Think about those other potential risk enhancers that might be contributing to his longer term risk. That's really important. Re-emphasize the importance of his lifestyle to keep his risk low as long as possible. And then, it would depend. This is off guideline, but if he was very, very interested, given his brother's recent MI, in lowering his risk for the long term, we know that the earlier we start lowering his LDL cholesterol, the bigger the impact will be over time. So we're not treating him really for the next 10 years. I think we're thinking about the longer term. And that's where the patient's values have to come into this decision and into this discussion. So really understanding that what he's after is really important here. If he's on the fence but would like to know more, I think he's a great patient to do a coronary calcium score in, right? He's 40. He's right at the age where the yield starts to increase. If we look at the whole population in 40-year-old men, maybe about 5% will show you some coronary calcium. So the yield there is pretty low, right? You have to screen 20 people to find one person with a positive coronary calcium. However, that's the whole general population. If we take somebody who's already enriched because of this family history, because of that Lp(a), the yield might be a little higher. So if he's willing, sadly, to pay out of pocket, that's still not fixed yet, but we're working on it. If he's willing for a coronary calcium score, I think that'd be reasonable. A reasonable way to kind of go after this. What do you think? What would you do?
I think that is very appropriate. I think the main consideration here is finding those factors that would perhaps push us one way or the other to initiating statin therapy. I think obviously, like you mentioned, this should be a collaborative effort. If he was really interested in kind of, he saw what his brother went through and he really wants to try to lower his risk as much as possible, and he's okay with statin therapy, that would perhaps be something, we should just go ahead with. But obviously if he's sort of on the fence, then I think other testing like a coronary artery calcium score could be very helpful.
Yeah. And Frank, if it's 0, I think that buys him some time, right? Yeah, but would you then repeat it at some point?
Yeah, I think he's someone who, especially, given his fairly young age, could go on to develop, coronary artery calcification. So I think, within the next several years, if he's obviously interested in getting repeat testing, that would be something I would consider.
Yeah, totally agree.
Great. And then the final question is just, I think this was highlighted very clearly in the guidelines, but any cascade testing, he has young children who he's obviously concerned about whether they could be at risk.
Yeah, and we certainly would recommend cascade testing for his children. I usually would wait until after puberty, so later adolescence, just to understand, once their lipid panel settles down after puberty, what are we really looking at? They should be screened for FH much earlier, of course, at ages 9 to 11. But in terms of the Lp(a), I would check that with a standard lipid panel in later adolescence, given that they are related to their dad as first-degree relatives, just to understand. And again, likely we wouldn't be pushing for medication at those young ages, but it might give them some benefit to know that they need to be particularly careful with their lifestyle to prevent the elevations in the other risk factors over time. So that's important. Certainly, all of his siblings should be tested as well, including the brother who had the MI, because it might lead to more intensive therapy and a lower LDL cholesterol goal. But even his parents, if they're still alive, I would test. So all first-degree relatives in the circle around that patient.
Excellent. Then moving on to the next case. So we have even younger.
You're making it harder as we go.
So a 25-year-old woman, she presents to primary care clinic to establish care. So she herself doesn't have any significant cardiovascular risk factors or history, but she does have a significant family history with multiple family members on her father's side having early cardiovascular events. She exercises and feels great at baseline. She hasn't had her Lp(a) checked yet, as she was wondering if she should, based on some of the articles she's read online about its ability to help predict who might develop risk. And as you might expect for a 25-year-old, fairly unremarkable history, as well as vital signs, laboratory values. Her lipid panel without the Lp(a) looks actually quite good. And her prevent risk there, as expected, are to be very low. So I think this was the first question. I think was answered very well in your presentation. But would you recommend Lp(a) testing for her? She did express during the visit that she had some anxiety about finding out the results, but obviously, is also curious given her strong family history.
Yeah. So, I think anxiety might be understandable. This would be telling her that she might have a factor that increases her lifelong risk for cardiovascular disease. And so, I would sort of start maybe with reassuring her a little bit that we're not giving her a diagnosis that's going to affect her risk tomorrow. even if her Lp(a) is high. And that's largely due to the good work that she is doing, right? She's clearly very active. Her lab results are enviable from my perspective. And so she's doing an awful lot right here, which is going to keep her risk low in the near term for sure. And we've got time. We've got time to figure this out. It's unlikely with that standard lipid panel that we're going to need to recommend medication anytime soon. But over time, her LDL is likely to go up. And, this is something that, we need to keep an eye on for her and really maximize her lifestyle approaches. So trying to empower her to give her, regardless of the Lp(a) result, a lot of this is in her control. And I find that a lot of patients kind of respond to that. So, I understand the anxiety around any kind of testing like this, but I think we can help her see it again as a motivating factor, like we talked about earlier.
Yeah, absolutely. And I think, we showed that her LDL was fairly good. It was 107, but I'm curious if, let's say her Lp(a) did come back at, 200-300.
Yeah.
How would that change how you think about her risk? And, let's say if her LDL was actually not as good as 107, but rather 170, how would you think about her risk? And would that push you towards preventative therapies now?
Yeah, so 170 at this age, and again, it's going to go up over time. She may actually be trying to tell us that she actually has the FH phenotype. She might not have monogenic familial hypercholesterolemia, but she may have polygenic, contributions to severely elevated LDL cholesterol. At 170, I think we need to have a very serious conversation with her, especially if her Lp(a) is elevated, about whether drug therapy at this point wouldn't make sense. And, I think it would make sense, especially if she's got both of those factors so elevated. Special considerations, of course, in a younger woman of reproductive potential, where we need to have the conversation also about contraception, and when and if she's planning to actually get pregnant, that she knows to stop the lipid-lowering medications under the care of a doctor about 3 months before she tries to conceive. And if she were to get pregnant unexpectedly on the drug, she should stop it immediately and again consult with a physician. But with an LDL of 170, I think we're looking for reasons not to treat her, especially if that Lp(a) is high. I think if we were to treat her, I would be looking for certainly at whatever level of LDL. For starters, I'd at least want to get her less than 100. So if 107 is true, I think lifestyle is what's in order. If she's starting at 170, well, then I think we're going to, lifestyle is not going to get us to where we'd like to be, and we need to have a conversation with her.
Absolutely. And then just a follow-up question to that, because she's just overall so low risk based on her other, I would say, traditional risk factors, are there any other risk assessment approaches, especially, I guess, over the next 5, 10, 20 years, are there certain approaches you would take to kind of delineate whether her risk is appropriate for therapy at that point?
Yeah, it's a great question. I think that polygenic risk scores are emerging as something we might consider someday. I don't think they're quite ready for prime time yet, but I would start to set the expectation with her that on or before her 40th birthday, we need to do some sort of imaging, maybe a coronary calcium scan when the yield is starting to increase. And in the meantime, let's keep her great looking, risk factor profile as great looking as possible. So anything else you might consider here? Absolutely.
Yeah. So I totally agree with you. I think obviously coronary artery calcium scores have the best evidence to support them. There is sort of emerging evidence that maybe Lp(a) preferentially increases non-calcified plaque. So, that could potentially get missed on a coronary artery calcium scan. So there's accumulating evidence that perhaps, coronary CTAs to really look for that non-calcified plaque could be a strategy going forward. Obviously, at this age, we want to limit her radiation exposure, but perhaps, like you mentioned, in her early 40s, that could be a strategy we could consider.
Yeah, great. Well, we only have 2 minutes, but I'm going to try to rapid fire some of the questions. And let me reassure attendees that we're going to get all the questions and we'll try to respond to them to you directly as well. So Should it be tested in the primary care setting? Absolutely. I love it when patients are referred to me with it already measured. You don't have to be fasting to measure Lp(a) because it's not affected by that. So fire away. Should it be measured in the hospital when the patient comes in with a TIA stroke? Yes, that would be an appropriate setting as well. Should it be a stroke metric? Yes. When did these newer assays come out? Well, they've been available for a couple decades, but they've been getting better and better. And now the real advance is they are more standardized. So you should ask your health system or local lab for the nanomole per liter assay, not the milligram per deciliter assay. Are coronary calcium levels reversible? No. Remember, the calcium is an indicator of plaque. It is not the plaque. It's a response to plaque. So that doesn't reverse once present, but that's not a bad thing. So don't remeasure coronary calcium once you've started treating someone because it will only go up over time. So that's probably all the time we have. We're at the end of our hour. I want to thank you all so much for attending, and I'm going to turn it back to our AHA staff.
Thank you, Dr. Lloyd-Jones, and also Dr. Qian. You all both had a great, wonderful, excellent discussion and presentation. To our audience for your engagement today, also thank you. We got plenty of questions. We will get them answered and emailed to you with a follow-up. We encourage you to explore our Lp(a) patient education resources at www.heart.org/Lp(a). Forget what the Guideline customers, new Lp(a) elements such as value, unit, and treatment plan are now available in the stroke and coronary artery disease modules. Also, when you exit the webinar, there's going to be a brief feedback survey that will appear in your browser. Your input is greatly appreciated. This helps us tailor future Lp(a) education to your needs. So please fill that out. Thank you again for attending today's webinar. We hope to see you at future Lp(a) webinars. Have a nice day.